know, that's the premature closure or absence of one of the cranial sutures. And as I mentioned before, the way the brain grows, it needs that space and that responsive skull growth to continue to grow normally. And so when the sutures close prematurely, it's going to cause a problem for brain growth. So I put it right after plagiocephaly because sometimes what happens if a single suture becomes bound up, then the head's going to grow in the axis that it has the ability to grow. So it may actually lead to plagiocephaly. Associated problems with craniosynostosis, ocular problems, neurologic problems, and then, of course, the most common is the increased intracranial pressure, which is obviously bad for everybody for any reason, but certainly bad for a baby whose brain is still growing. Sagittal sutures most commonly involved, and the definitive treatment is surgery. So one of the things you have to differentiate is secondary microcephaly from primary craniosynostosis. So is something happened that's arrested the brain growth, or have the sutures fused? So that's the basic question. And some of the easier ways to do it is to look at the brain. So if you have concerns about it, you want to get an image of the brain and make sure that it's developing normally. And then you can do some bone windows to look at the sutures to make sure that they're still open. All right, we're going to talk about some growth problems. And then we're going to take a break. All right, so this is a reasonably short section, but very important because this is another section that the boards are invariably going to test your knowledge on, is normal growth. So as I mentioned before, one of the most important things in your approach to these questions on the exam is to identify the pattern. Don't look at a single value, but think about where the pattern has gone and think about the nature of that pattern and recall the differential diagnosis once you identify the pattern. So if the growth pattern occurs, the type of growth pattern that occurs when there's been a prenatal insult is what you would expect, right? All of those parameters tend to be down. So birth weight, height, head circumference all tend to be low, and they continue to fall away from the population means on all of those growth parameters. That's typical of a prenatal insult. So the kinds of things that are prenatal insults are intrauterine hypoxia, any other cause of intrauterine growth failure, or a genetic abnormality. The pattern in growth that you're going to see if it's a postnatal insult is you're going to see some normal parameters at birth, and you're going to see a falling off of one or more of those parameters from the normal curve as development goes on. Now, one of the more interesting patterns that you're likely to be presented with is caloric insufficiency. So that's just a situation in which the baby's not getting enough calories. So either they're not being given enough calories or they're consuming more calories than is normal. So what often happens then is you see a significant weight loss or a failure to gain weight, but the body's very good at preserving height and even better at preserving head circumference. So as parameters fall off, it's most likely you're going to see a drop in weight or a failure to gain weight before you're going to see a failure to gain height or a failure to increase the head circumference. In severe cases, they'll all go down, but more commonly it's the weight that's affected. So here's a particular case, the case of Jake. This is an 8-year-old male, firstborn. He was healthy, no significant past medical history. Parents are both healthy. Review systems was negative. He went through a normal term pregnancy and delivery. Growth parameters at birth and for the first year of life were all between 25th and 50th percentiles. And between 1 and 5 years of age, all the growth parameters gradually fell to less than the 3rd percentile. So he went to between 25 and 50 for the first year, and then between the ages of 1 and 5, gradually dropped all the way down to the 3rd percentile. Since the age of 5, his growth parameters have all been tracking just below the 3rd percentile. Both his parents are between the 25th and 50th percentile for adult height and weight. So what's the most likely diagnosis here accounting for Jake's fall in his growth parameters? Is it A, cystic fibrosis, B, hypothyroidism, C, growth hormone deficiency, D, constitutional growth delay, or E, osteogenesis imperfecta? So grab your button box and pick one of those. So excellent. So most of you recognize the correct answer. This is a classic presentation of what's called constitutional growth delay. Cystic fibrosis is not a bad choice, but you'd expect that there'd be some associated recurrent infections or some other sign of the disease, and that he'd have a failure to thrive that was greatest with his weight and less concerning for his height. Hypothyroidism probably would have an earlier presentation, and growth hormone delay tends to lead to reduced growth parameters from birth rather than being born with normal parameters. And then osteogenesis imperfecta, is a severity of different levels depending upon the type that you have, but leads to recurrent fractures. So this is the typical presentation of constitutional growth delay, and really the pattern of this presentation is what defines the condition. It's usually familial, so when you ask parents, you'll find that somebody in the family often had it. They're born with normal birth and weight parameters, and then typically will drop off during the first 2 years, and then follow their own curve, usually around the 5th percentile. And then most of these kids, well, not all of them, most of them will experience a significant growth spurt in which they actually often will catch up to their peers. And some of them don't, but most of them do catch up, and so they're in that growth spurt then crossing back up through those percentiles. So we're going to shift to a little bit about bone age because you need to know how to measure that. And I've got a question for you here. For this particular patient with constitutional growth delay, what bone age would you expect? So if you checked it in this 8-year-old with this presentation, we expect A, a delayed bone age, B, an advanced bone age, C, a normal bone age, or D, there's no relationship between bone age and chronologic age in this condition. Should we pick one of those? All right, excellent. So what you recognize in this is that this patient actually has growth potential, which means that their bone age is typically going to be delayed. So in constitutional growth delay, usually involves reaching a normal height. The final height's usually on the shorter end of normal, but the bone age typically lags behind the chronological age prior to the adolescent growth spurt. And so there's no particular magic to bone age. If you've ever seen a radiologist do bone age, you order plain films of the hand and wrist, and then what does the radiologist do? They basically open a book. They open a book and they find the picture that closest matches the films. It's that simple. And the book generally is by month. And so, you can target the bone age to the month as opposed to just the year. And what you'll find is that chronologic age, so for example, in a chronologic age of 10, if the bone age is 10, that means that you expect their current rate of growth. If their bone age is 12, you actually have a reduced expectation for growth. And if their bone age is 8, you actually have an increased expectation for growth. So just remember in constitutional growth delay that it's typically the third of those possibilities where your bone age is actually delayed, representing that growth potential that's there. Okay, another problem that's reasonably common and one that you're pretty sure to face on your exam is failure to thrive. So failure to thrive is actually a descriptive term, and when you look at resources, there are a variety of definitions. What you're usually managing is not actual weight loss, but rather poor weight gain. In very severe cases, you may be faced with weight loss. Length and height, as I mentioned before, and head circumference are only affected in the most severe cases, but the parameters depend upon the source of the problem, the severity, and the duration. Some of the definitions that you might see talk about a single point, but I spent a lot of time trying to convince you that that's not a good way to look at anything, so I'd rather you not look at it that way. but rather from a trend. If you look at it from a single point, some of the definitions will have weight less than the 3rd percentile, weight for height less than the 5th, or weight 20% less than the ideal for height. If it's defined from a series of points, then you're talking about the weight trajectory, and that's probably much more useful and a better way to measure it. So I don't think you need to memorize any of these, but what you need to just recognize that looking at it as a trend is probably better. When we talk about major percentile divisions, again, you know that those divisions are very arbitrary. That's where somebody at some point decided to put them, but there's no biomedical significance to those. So an identifiable organic etiology is almost never found. So it'd be even stronger than usually not found. It's almost never found. Although organic etiologies are obviously something you wouldn't want to miss, it's very rare for them to present as failure to thrive alone. They usually present with some additional symptoms. So when you're looking at the exam, consider an organic etiology if it's coupled with a developmental delay, you have concern about the IQ of the child, or you find some physical exam abnormality. That probably should kick you into another category. But what I can tell you is that the most common cause of failure to thrive is the psychosocial situation. So previously was thought of as a rule-out diagnosis that those kids who came in for a failure to thrive workup were always put through the same ringer of exams, and we're really being encouraged not to do that anymore, but rather to target your workup based on the history that you obtain and any physical findings or any suspicions you may have. But you can certainly do that workup in parallel, right? Consider the psychosocial workup along with the biological workup. Because one of the more important things about doing it that way is that when you consider the psychosocial causes from the get-go, it's not going to be a surprise to the parents when you come back to them and explain to them that it is indeed a psychosocial problem. So rather than giving them the impression through your long list of testing that there is a biological cause. So if you look for the differential diagnosis of the medical causes of failure to thrive, there are two easy ways to look at it. One is that the child's not getting enough calories, and the other is that they have increased caloric needs. So they're not getting enough in, they're wasting those calories they are getting, or they've got increased caloric requirements. So that's sort of those are the buckets that I'd put it in your head. So for the medical causes, the social causes are usually not enough calories coming in, right? So that's usually the kid's not eating enough calories because of the social situation. If you're getting enough calories in, then the possibilities are that you're wasting some of those calories, or you have an increased caloric requirement. So you're not absorbing those, or you're using way more than would be expected. So for causes of excessive losses, you think about gastrointestinal disorders or renal disorders. And for increased caloric requirements, we think about chronic disease. So we think about cardiopulmonary disorders, malignancies, hyperthyroidism, or a chronic infection. Those are all conditions in which you'd require more calories in. So for the medical evaluation, make sure you review the past growth data as we've talked about. Do your history and physical and a developmental assessment. This is probably the most important thing you can do, is observe a feeding session. Make sure that you take the opportunity to watch how the child feeds, because it's likely that you'll learn more from that than any lab test you're going to get. So you want to look at the parent-child interaction carefully and then be selective about the labs that you choose based on what you've found so far. So there isn't the failure to thrive panel anymore. You really need to think about what you're considering as the cause and then target your lab ordering based on that. Any child with failure to thrive should be hospitalized if you're concerned about abuse or neglect. If there's severe malnutrition, if the patient's at all medically unstable, or if you've already tried outpatient management to manage the failure to thrive and you've failed. Developmental delay is another topic area that's going to be on your test. So there are a couple pearls to think about. When you're doing your developmental testing, most of that developmental testing requires that the patient cooperate. So if there's any indication that the patient's unable to cooperate, you're your testing is probably going to be rendered invalid. Again, with the preemies, you need to correct. And think about physical abnormalities such as hearing and vision problems that are going to affect developmental delay. Again, that knee-jerk reaction, when you're faced with a question where the child has developmental delay, make sure that you screen the hearing and vision first. So how do you evaluate developmental delay? Your full history and physical, making sure you look at the family history, a complete review of systems. That psychosocial assessment becomes really important. You need to know something about the birth history and what went on. Was there a possibility of a prenatal or a perinatal insult? And then your hearing and vision screens, as I mentioned, and then everything goes from there. So make an educated assessment before you order your lab tests. Consider in the evaluation of a child with developmental delay, the test you would want to think about would be the newborn metabolic screen. You want to check back and make sure it was normal. You want to check and make sure it wasn't done too soon, like we talked about before, because if the child was discharged early, it might be that the toxic metabolites didn't build up to a level enough that was able for the test to detect them. But the more common things that you want to think about are lead, thyroid disease, and genetic abnormalities. Really, MRIs or other imaging of the head is generally not necessary in failure to thrive, unless the failure to thrive is associated with any of the things on this list. But these are all neurological problems that you would be concerned about anyway. So again, it's a failure to thrive that's not of a social nature, rarely occurs with anything other than failure to thrive. So if it's associated with any of these other things, you need to be thinking about a more significant diagnostic approach. All right, we're going to make a transition now to some of the more socially based issues that come up in general pediatrics. I'm going to try to cover the more common of those. So the first is the birth of a sibling, and we're going to start with a question. And this will hopefully be easy for you general pediatricians out there, or even you parents. Which of the following is the most effective way to minimize problems an older sibling will have with the arrival of a new baby? Is it A, move the older sibling into a new bedroom just before the arrival of the baby? B, avoid talking about the new baby to the sibling? C, discuss the importance of the new baby and why he or she will require special attention? Or D, ensure the sibling has special time alone with the father or another important person? Which of those is the best choice? Okay, you nailed it. So yeah, the best choice is to actually provide a positive something for that sibling as a result of the birth of this new baby. C is not a bad choice, but again, there's already going to be enough. Kids are usually born at a time where they're close enough in age that the older sibling doesn't have the capacity to empathize. So you need to point that out to your parents. So when parents are having these protracted discussions with the 2-year-old about how they need to understand this, that, and the other thing, you just tell them, you're kind of wasting your time, because the 2-year-old does not have the capacity to be empathic. So just face that fact. Basically what you're dealing with is the displaced queen or king. And so the universal reaction is hostility and aggression. That's normal. So you might even see in the sibling some developmental regression, like thumb sucking, or some regression in toilet training. The older sib can become sad or withdrawn. This is all normal. That's the important thing to point out. So how do you prepare? You allow the older sibling to participate in the planning. Allow them to help in the care of the newborn as they are able. Important phrase, as they are able. No change right before the arrival of the sibling. That's just a bad idea, because then the displaced king or queen recognizes all these nasty changes that are occurring with the arrival of the new baby. So special time for the sibling with another adult is a great way to do it. All right, occur in almost every 2 to 4-year-old, sometimes daily, may appear as early as 7 months. Yeah, it's amazing. Usually resolved by the age of 5, although my wife disagrees with that. All of the following are reasonable advice to give parents of a child having frequent temper tantrums except. So grab your button box and let's pick one of these. So all of these are reasonable pieces of advice with the exception of one of them. So A, redirect the child to something else. B, remove the source of the tantrum. C, ignore the tantrum. D, avoid situations that provoke the tantrums. Or E, punish the child for the tantrum, which is unacceptable. You guys are good. So, A through D are actually effective ways to deal with it. And I always admire that parent who's in the grocery store aisle with the kid, absolutely having a fit. And they're just totally ignoring them. And I'm like, you're doing it right, but I'm really glad that's your kid, not mine. All right, a little bit of sleep. Another question for you. The parents of a 6-month-old female come to you for advice on helping her sleep better. The parents describe that she has trouble falling asleep and wakes up several times in the night. The remainder of her history is unremarkable and her physical exam is normal. Which of the following is best advice to give? A, always place her in her crib awake. B, feed her right before putting her to bed. C, rock her until she falls asleep, then place her in her crib. Or D, move her to the parent's bed so she can be consoled more easily. Don't laugh. That was a good distractor. All right. So I guess it's A, B, or C. Right. So the general rule at this point is, it's better to allow the child to learn how to put him or herself to sleep. Parents get in traps because they employ all sorts of mechanisms to put their kids to sleep, and then the kids depend on those mechanisms. So, you create these problems, and the parents are usually the source. So with most sleep problems, that's true. So awakenings are a very common complaint. One of the thoughts is that a lot of this is misinterpretation on the part of the parents, that these are actually not awakenings, they're normal parts of sleeping, and the problem actually is the parents are intervening. So as they say, let a sleeping infant lie. The parent is often responsible for the actual waking up, and you've got to stay away from these bad habits. So for infants, the general recommendations to solve sleep problems: create a routine. A daily routine is most important. Make sure the infant has his or her own bed that's not in the parent's room. Put the child down awake, and don't feed the child at night or even right before bedtime. And those middle-of-the-night feedings can stop as early as 4 months, but certainly by age 6 months. For older infants, the best technique, even though it's painful for the parents, is to ignore the awakening. And in most situations, you'll find that if the parents truly can ignore the awakening, that behavior will extinguish pretty quickly. So infants then develop the ability to fall asleep on their own. And if parents are going to do anything, you tell them that the most they can do is provide some verbal reassurance from the door, but there's even controversy about that. For toddlers, even infants with good sleep habits can become toddlers with sleep problems. So it's very common for toddlers to have sleep problems, even when the parents hadn't had sleep problems up to this point. It's just the nature of being a toddler is to resist everything, not just going to bed. So, it's part of their resistance nature that they don't want to go to bed. And any time that you travel or there's an illness that's going to disrupt even the best routine, so it's important to reinforce with the parents, it's important to be firm, have rules, stick to them, and don't bend. So have a regular pre-sleep routine. It's a great time to take a bath or get ready for the next day, brush teeth, reading books, and so on. But be firm with the toddler's attempt to derail the process, because you know that they will, and it's just it's time for bed. For school-age kids, it's important to start the transition of giving them more responsibility for this process, but also using the time as a really special time for parents to bond with their kids and say debrief the day or talk about how the day is going to go the next day and spend time reading together. For adolescents, it's like in every other situation with adolescents, step away. Just don't get involved and step away from the adolescent. No, seriously, it's important for them to learn how to establish their own routines and make that transition to adulthood. Although the parents are going to need to provide some guidance, obviously. All right, we're going to talk about some things that are called parasomnias. And there are a variety of different parasomnias, everything from grinding your teeth to a variety of strange behaviors. First of them is nightmares. These are disturbing dreams, usually followed by awakening and some distress. The child can recall the nightmare, usually peaks about 3 to 5 years. They're extremely common, although recurrent nightmares may be an indication of some excessive stress in the household. There is a special type of nightmare that's experienced by participants in review courses in pediatrics. These nightmares generally involve falling asleep during the exam and waking up with only 2 minutes left, or discovering that you, in fact, got into the neurosurgery exam instead of the pediatric exam, or that you realized at the exam that you forgot to get dressed. Nightmares. How do you handle them? You reassure the child. This is where they actually remember what happened. You tell them the dream is over, they're safe, that it wasn't real. Sometimes it's helpful to debrief them the next day. But frequent nightmares should lead to exploration of whether or not there is some stress going on in the family. So night terrors are different because night terrors are a parasomnia that the situation is the child appears to be awake but is in fact not. And so during sleep studies when this happens, the child actually is not in a wakeful state. They're in a sleep state. Now, the child is unresponsive. They're inconsolable. They may be crying. They may be screaming. There's nothing the parent can do. And so you need to just tell the parent, you just keep them safe and just it'll pass. The good news is the child doesn't remember these episodes, and they're less common than nightmares. So for night terrors, again, just keep the child safe. With all the parasomnias, if they become a real problem, you can actually disrupt them by disrupting the natural sleep-wake cycle. So as an example, the parasomnias tend to occur right in the transition to deep sleep. And so what you want to do is disrupt that cycle. And so if the parent is having a really bad time with a kid who's having night terrors, for example, and they tend to occur at a certain time at night, that's because of their sleep cycle. So if they're going to bed at, say, 8:30 or 9, and their sleep terrors tend to be occurring around 11, what you can do is the parent can actually wake them up at about 10:30 or so and reset the cycle. You'd obviously rather not do that, but that is a way to prevent the terrors from happening. Sleepwalking, same kind of thing. The child appears awake, but in fact they're not. And the famous rumor with the toddlers, or especially the preteens, is wake somebody up while they're sleepwalking that they die or something horrible happens like that. Of course, none of that's true. And how do you handle sleepwalking is basically just ensuring the environment is safe. This is something that definitely tends to be familial. So when you ask patients about it, often there was a parent or an aunt or uncle who had a lot of sleepwalking. But there's no problems with sleepwalking. It's not an issue the parents need to worry about. Just keeping the child safe is the important thing. Bruxism, as what also occurs as a parasomnia, it's the grinding of teeth, and it's typically related to a certain sleep stage as well. But it can have significant medical consequences. It can cause temporal mandibular joint syndrome, tension headaches, facial pain. You can actually wear down the teeth if it's serious enough and cause some damage to the supporting structures. So the general recommendation is for you to refer these patients to a dentist who can make a simple mouth guard. It won't prevent the grinding, but it will prevent the damage to the teeth and soft tissues. Talk a little bit about habits. Here's another question for you. The parents of a 7-year-old boy ask your advice about his nail biting. He's been a nail biter for a couple of years, and the parents are really upset about it. He has no medical problems and no significant medical history. Which of the following is the best advice to give the parents? A, take away privileges whenever he's seen biting his nails. B, apply bitter-tasting nail coating to his nails. C, ask his teacher to remind him not to bite his nails. Or D, ignore the behavior. Which is the best choice? So D is the best choice, in fact, to figure out a way to ask the parents to, as much as they can, ignore the behavior. It's not always easy. The other things are choices that you could employ. The problem with A is if you just take away privileges whenever he's seen biting his nails, it may just cause him to go underground. B, the bitter tasting stuff actually can work. But the problem is you need to reapply it every time he bites his nails. And I probably C is probably the worst choice. I'm sorry for the 1% of you who picked it, but getting the teacher involved here probably is not going to be a good thing. So strategies to address habits. Parents tend to overreact. Universally, that's true. Instead, it's better just to ignore the behavior. There are attempts by parents to stop the behavior, often can lead to reinforcing it and just highlighting the behavior. So the best thing is to try to get the parents not to react so strongly, providing positive reinforcement when the kid's not engaged in the behavior, although some specific measures may work. Thumb sucking is another really common one. It's been documented in utero. It is very common, 20% of kids. Usually it stops on its own. So again, most of the time you don't need to do anything. It usually resolves. But usually cause no problem, but there are situations when you can actually get the thumb sucker's teeth being affected as they develop, where the incisors are being pushed forward. In that situation, you can ask your dentist to help you out. They can develop a device that returns the teeth to the normal position and prevents that from happening. Okay, as I promised, we're going to talk about colic. And we'll start out with a question. The parents of a healthy 6-week-old boy report a pattern of crying consistent with colic. There are no other complaints and no other medical history. A complete physical exam is normal. How do you best explain colic, and what do you recommend to the parents? A, the cause of colic is unknown. Recommend a variety of interventions, hoping one works or one helps. B, an infant is experiencing abdominal discomfort due to formula intolerance. Recommend a trial of another formula. C, colic is caused by excessive bowel gas. Begin a trial of simethicone. Or D, the infant is constipated. Begin a trial of stool softener. Which is the best explanation of colic, and what do you recommend? So good. The answer, in fact, is A. The cause of colic is not known. It's thought to be a syndrome of some type, and I'm sure in the not-too-distant future someone will discover what causes it. But the best thing to do is to recommend a variety of interventions and hope that one of them helps. Often, none of them help. So that's the unfortunate reality. Normal amount of crying is important to remind parents. 2-week-old infant cries 2 hours a day on average. More than most parents realize, and it increases to 3 hours by 6 weeks, but then decreases to an hour a day by 3 months. And most of this crying occurs in the evening hours. There are some known features of colic. It's a syndrome of findings that's thought to be due to a specific condition, although nobody really knows what it is. There are theories that it's maybe a hyper-irritable GI tract, or there's some other sensitivity. Hasn't been fully defined. Characteristics are crying bouts that are paroxysmal, prolonged, and refractory. They're unexplained. They begin and end without warning. And so what's the most distressing thing? That parents can't do anything about it. So you reassure parents it's nothing they're doing. It's nothing they're doing wrong. It's a phenomenon that occurs, and it's hard to live through. The most important thing is for parents to have support mechanisms in place so that they can have others to help them care for their baby when they're colicky. But there are a variety of things that parents find works, right? You know, a variety of different noise makers, putting them in their car seat and taking them for a ride in the car, you know, all sorts of things. You sometimes hear parents say, well, put them on top of the dryer. I don't recommend that, but sometimes you hear that that helps. So, you know, you have to allow parents, you give them some choices and say, these are things that some people find works, try them. So here are the rule of threes associated with colic: 3 hours a day, 3 days a week for at least 3 weeks. You don't make the diagnosis before 3 weeks of age. You don't make the diagnosis after 3 months of age. So that is to say, when you're faced with this situation and it's after 3 months or before 3 weeks of age, you really need to be considering other possibilities. It occurs in 30% of babies and usually after 3 p.m. It's a lot of threes. All right, how do you treat? It's really difficult. Most improve by 3 months of age, but about a third persist to 4 months. So lots of reassurance, the parent's not at fault. Educate the parents a lot, make sure they have a lot of backup and help. When it's not colic, when its onset is greater than 4 months, any finding on history or on physical, you know, one of the things you always want to look for is what's called a hair tourniquet, right? So the baby gets a hair wound around its pinky. Boys can have it wound around their penis. I mean, you have to look for things that obviously might be causing pain. That's a totally different situation. If the cry is high-pitched, if the bouts are not daily, these are all things that you want to think about might be causing a syndrome other than colic. All right, recurrent abdominal pain, incredibly common. About a third of children report abdominal pain that lasts for 2 weeks or longer. There are a range of ages, but it typically occurs between 6 and 14, with a peak incidence between 7 and 10. And it's defined as pain that occurs at least 3 times in 3 or more months. It usually is described as around the umbilicus by the patient, and it can affect the activities of daily life. So it's a real pain. An 8-year-old girl here has recurrent abdominal pain. After a complete history and physical exam, you suspect a diagnosis of functional abdominal pain. Which of the following data is most important to collect before finalizing your diagnosis? So you have an 8-year-old, recurrent abdominal pain. Which of these things do you want to make sure you look at before making the diagnosis of functional abdominal pain? Is it A, a diet log, B, a white blood cell count, C, growth curves, D, abdominal x-ray, or E, report from school on possible problems? Which of those do you want before you finalize your diagnosis? So a little bit of a split decision here. Yes, I think, you know, all of these things are reasonable. Maybe, you know, I'm not sure how a white blood cell count would help you, except to make sure that she isn't having an intra-abdominal infection. Dietary log could help because, you know, there might be foods that she's having problems with and others that she's not. An abdominal x-ray may or may not help you. The likelihood is, the overwhelming likelihood is, in this situation, it's going to be normal. There was nothing about her stool pattern in that question, so that might be something you'd want. There's nothing about whether or not she's hemocult positive, so she has occult positive blood in her stool. But of the choices that are left, certainly kids who have recurrent problems like this are often having problems at school. They're being bullied, or there's something going on at school that is being manifested as pain. But I think the best answer is C. You want to make sure that this isn't affecting their growth. So it's categorically uncommon for functional abdominal pain to lead to weight loss or failure to gain weight. So if you've got a situation where the child's failing to gain weight or is actually losing weight, you shouldn't be making the diagnosis of functional abdominal pain. So common in children and adolescents. It's important to realize this pain is real. So one of the biggest issues you're going to face with the parents is that, you know, you're going to come back to them and say, this is what we call functional abdominal pain, and it works like this, and this is what we think causes it. And the parents are going to think you're saying it's not real pain. It's real pain. There's no question it's real pain. So the thing I like to liken it to is a headache. So it's not like when I get stressed out, I get a headache. That pain is very real. It's not that that pain's not real. It's very real. But I can't, there isn't something that I can necessarily say, this caused my headache or that caused my headache. So it's a functional disorder. It has to do with normal daily functioning. And it means that there's not something that's underlying this that's wrong. That's what's important to highlight. So requirements for the diagnosis: normal physical exam, stool's negative for occult blood, none of these signs or symptoms, involuntary weight loss, growth deceleration, vomiting, diarrhea, fevers, family history of inflammatory bowel disease. Then you can say, okay, it's probably functional abdominal pain. Possible explanations: we already talked about stresses at school, a relative with a model. Some kids just have a temperament that when they get stressed out, they get abdominal pain. There could be secondary gain, getting additional attention, getting out of school early and such. But only 5% of children with recurrent abdominal pain are going to have an organic etiology. And those that are most common: constipation, cholelithiasis, gallstones, inflammatory bowel disease, pregnancy, always worth considering in an older child, UTI or lactase deficiency. But the goal of treatment, and this is really important, the goal of treatment is not to take away the pain. It's not to convince the parent that the pain's not real. The pain is very real. The goal of the treatment is to convince the child that he or she needs to continue to function on a daily basis in spite of the pain. All right, ADD and ADHD, another sort of hot topic these days, sort of how we manage this, how we diagnose it. Characterized by a short attention span, impulsivity, and overactivity if ADHD is involved. Again, another syndrome that we don't know the etiology. Good chance genetics are involved. There's been questions about whether it could be alcohol or toxins in the environment. Nobody knows for sure. What we do know is that well-controlled, extensive studies have shown it's not related to sugar intake, and it's not related to artificial sweeteners or flavorings. So the clinical findings fall into one of these 5 categories. The kids are very distractible. They tend to be impulsive. They have a hard time making sort of decisions that require reason. They're hyperactive. They have an inability to plan tasks, so they don't have the ability to sort of map out what they want to accomplish and the steps through which they want to accomplish it. And they tend to be labile emotionally. So the diagnostic criteria I've listed for you, but some of the things to recognize is that it needs to occur before the age of 7 in order for the diagnosis to be made, and the symptoms need to persist for more than 6 months. A really important one is it has to be in more than one setting. You cannot diagnose ADHD if it's only occurring at school. So that's an important thing to highlight. So 6 of these 9 criteria have to be present, and these you can assess, through questioning or there are lots of tools out there that you can use: parent questionnaires, teacher questionnaires, things to help you gather data. For the hyperactivity, impulsivity of the ADHD criteria, again, 6 of these 9 things, but they're generally things that can be assessed through history taking with the right sources. And generally, there's no lab workup indicated, although you might think about lead screening and TSH, depending upon whether there are other associated features or whether or not either of those are a concern for you. No EEG, no MRI. So treatment. The crux of treatment needs to be multidisciplinary. That is to say that there need to be lots of different people with different backgrounds involved in this child's treatment. So it's not something that a single person can treat successfully. So the school counselor needs to be involved, the teacher needs to be involved, maybe that you need a psychologist involved, you need to be involved. So there are a variety of different people with different skills. It's a multidisciplinary approach. That's what works. Behavior management needs to be a part of it. That isn't to say that we think that this is a behavior problem. It's not. But what we do know is that these kids can learn adaptive behaviors. And so that's how you use behavior management to help teach them those adaptive behaviors. So it's helping them learn through positive reinforcement, reinforcement of what kinds of things are going to work better for them, and timeouts for extreme bad behavior. Medication is beneficial to the majority of patients. As you know, stimulants are used pretty widely now. So one of the things that you're almost guaranteed to be asked is about the side effects of stimulant medications. So you need to know the side effects of these medications, because it's surprising how many kids are on these medications now. So growth suppression and appetite suppression and insomnia are all common side effects of stimulant medications. So you need to be thinking about that in your follow-up with these kids. So you may not even be the one prescribing the drug, and that's okay, but you need to be aware of the side effects so that you can manage those. Interestingly, too, is that tolerance to these medications doesn't seem to develop in these kids. So what is tolerance? Tolerance is where you're taking a medication that in order to get the same effect, you need to gradually ratchet up the dose. And that doesn't seem to be true of the use of stimulant medications with ADHD. So most of these medications are medications that do develop a tolerance in other patients, but it doesn't seem to be occurring in this situation. All right, we're going to talk a little bit about a difficult subject that's also likely to come up on your exam, and that is child abuse. The 3 million cases of suspected child abuse reported every year in this country, and 1 million of those are substantiated. Child abuse leads to 1,500 deaths every year, and 2,800 children are abused every day. 5% of those who are under 18 have experienced some sort of child abuse. So this is a hugely significant problem. And statistics show that child abuse is the #2 cause of death in children in certain age groups, and it's secondary only to SIDS in those 6 months of age and younger. And there are many who believe that many SIDS deaths are the result of child abuse. And it's #2 in the age group of children between 1 and 5 years old, second only to accidents. And many believe that, in fact, many of those accidents are, in fact, the result of child abuse as well. So there is something to recognize called the battered child syndrome. It's a constellation of signs and symptoms. And it's usually fairly subtle, so it's often not recognized, or it's attributed to something like a viral illness. So you need to be very aware that this exists. And you need to be very aware that it needs to fall on your differential diagnosis of those kids who present with symptoms that are sort of nonspecific. It has an incredibly high morbidity and mortality. And when you're looking at risk factors, this is helpful because it helps you raise your suspicion in certain situations in which it should be raised. And I'm going to talk about the risk factors as they relate to 3 situations. One is the abused child, the second is the abuser, and the third is the environment that they exist in. So first, for the child, it's known that certain children are at higher risk for abuse. And so it's important for you to know how to recognize that so that your antennae can be perked up, in particular in situations where these kids are at higher risk. So any chronic illness, developmental delay, a child with mental retardation, a child with congenital anomalies, what's thought of as a difficult personality. So we all know that there are kids out there that are just tough. They're hard. They're more difficult personalities. And those kids are at higher risk. Adopted children and stepchildren are also at higher risk. Characteristics of the potential abuser that are associated with higher risk: a history of abuse themselves. So if a parent was abused, they have a 30% risk of becoming an abusive parent. So incredibly high risk. Little social support, unstable family situation, a young parent, or having multiple children all put you at higher risk. If you're argumentative, if you tend to be more violent or unstable, you're at higher risk. If you lack an emotional connection to your child, so this is the classic sort of textbook situation where even your students or your residents will come to you and they'll say, you know, it was just weird. The mother just didn't seem connected to that child. Emotional immaturity, that's where the parent may have so much emotional immaturity that they actually expect the child to do things for them or to give them gratification. Any involvement of alcohol or substance abuse, and then psychiatric illness. Two important facts to realize: abuse usually occurs in the home of the child, and the abuser is usually someone the child trusts. So when you're looking at the patient's history, there are some red flags that should go up. If there's a delay in seeking treatment, if there's a history that's inconsistent with the physical findings, so that's where you find a physical finding on exam, and there's no explanation for it in the history. A history that's inconsistent with the developmental stage of the patient, that's where you get a story from what happened that the patient's not capable of. Okay, so that's a situation where the parents or somebody is reporting that this is what led to the situation, and you know this child's not capable of that developmentally. If the story is conflicting, changing, or you get different histories from different people, or unexplained injuries. So another question, a 3-year-old boy presents with a burn. Which of the following burns was most likely the result of an accident? Is it A, splotchy burns on the chest and upper abdomen, B, a burn on the sole of one foot, C, 3 circular burns on the back, D, a hand burn with a clear line between the burn and the normal skin, or E, a burn on the buttock? Which of those are most likely the result of an accident? So you're right, a splotchy burn on the chest or upper abdomen can occur, for example, if a toddler were to pull a pot of boiling water from the stove or something like that, or a cup of coffee off the table. The other situations actually should be very suspicious for you to be concerned about child abuse. So any burn by location, the location of the burn is really, really important. And so it's unlikely that one is going to get burned on the back or on the foot, on the bottom of the foot. It's also unlikely that there would be a strong line of demarcation, what's sometimes called a stocking glove distribution, where you actually look like there's a clear line between the normal and the affected tissue, or a burn in a place where patients don't normally get burned. And those are all things that should worry you about child abuse. So pattern, circular, stocking glove distribution are areas that are usually protected. So one of the more common ways children present from child abuse is with inflicted skin injuries. So bruises, burns, cuts, variety of different things. And just by location, there have been some pretty good studies that have just looked at the location of the injury and whether or not the case was eventually proven to be child abuse. And it is likely that it's an inflicted injury when it occurs in these sites. So upper arms, trunk, upper anterior legs, sides of the face, ears and neck are actually one of the more common places. Genitalia or buttocks. Sometimes the mouth experiences inflicted injury. And then more likely accidental if it's occurring in these kinds of places. Because, when you think about it, these are the kinds of places that toddlers and other kids actually do get hurt. So there tend to be the leading edges, things like shins and bony prominences, the lower forearms, and the forehead and the chin. Those are places where kids tend to get hurt through accidents. So even just the location of the injury can be helpful to you in raising suspicion for child abuse. So also recognize multiple stages of healing or multiple planes of injury. So as I say, if the bruises are brown, green, and yellow, those are all different stages of healing, and that indicates recurrent injury. Unusual locations, as I mentioned, pattern characteristics, if they're well demarcated, like linear, circular, or repetitive, not normal. Any injury in a non-walker, any type of head injury, skin, skull, eyes, mouth, brain, 50% of child abuse involves some sort of oral or facial injury. So over half the cases in these children. Any fracture in a non-walker should lead to suspicion. And again, any skin injury you should investigate. Fractures that specifically should raise suspicion, skull fracture, one of the most common fractures in abuse. A humerus or a femur fracture, especially if the child's under 1. any rib fracture that's from the grabbing of the child around the torso or from the application of blunt trauma. Any complex fracture often indicates that there are multiple vectors of force. So that's a situation where it's a bending and a twisting. That's not from an accident. Sexually transmitted diseases are by definition sexual abuse in a child. So that's with the exception, of course, of a congenitally acquired infection. And one of the problems is the signs of child abuse, this battered child syndrome. Many of these things are things that you would commonly find in children in daily practice. So what it really requires is for your suspicion to be raised. And so you need to use the combination of things that we just talked about to be concerned about any of these things that you see occurring in a child. Some of them obviously are more obvious than others. So, the mimicking of sexual behavior in a child is categorically abnormal. Problems with peer relationships, those are a little bit more difficult to interpret. So the take-home message is be suspicious. Shaken baby syndrome is something you might be asked a question about, and that's a clinical syndrome that's diagnosed with a constellation of findings. The question always comes up is, how do I know shaking a baby, like grandpa bouncing the kid on his knee, isn't going to hurt the baby? The point is that any witness who would recognize the situation that leads to shaken baby syndrome would know that this was a dangerous situation. So it's not the usual shaking and bouncing. The problem is that the baby lacks head control. And so if the baby's grabbed around the torso and shaken back and forth, that the head goes back and forth without head control, and you get what's called contra coup injuries of the brain and rotational injuries within the head that lead to retinal hemorrhages, intracranial hemorrhages, but no evidence of external trauma. So there might be some bruising or some rib fractures or something like that, but when you see this constellation of findings, your first suspicion should be shaken baby. And the outcome is not good. So the early mortality rate is up to 25%, and up to 90% of those who survive have a life of disability. So for the test, maintain a high level of suspicion. Look for those flags that I gave you in the history and physical, and you should consider child abuse in every single injury. And when you're going to miss the question is if you pick the choice that says go ahead and set the bone and send the child home, when in fact the right answer is you need to invoke protective custody and get the Department of Child Services involved. So you need to always choose that answer that's going to protect the kid. So make sure you look for those flags because you don't want to miss a case of child abuse. All right, we're going to talk about some common orthopedic problems. One of the most common is what's called benign limb pain, and I know you've all seen this because your patients complain of it, and you might actually have had a child who had it, sometimes called growing pains. Up to 10% of childhood of school-age kids get it. Typically it's at night. Often when they're going to bed, they complain that their legs just ache, generally ache. They don't point to the joint. They aren't able to localize the pain usually. Nobody knows what the cause is. It's usually bilateral. Patient describes it as sort of a deep aching pain. But you need to make sure the joint's not involved. There's no evidence of any physical exam abnormalities, and there's no inflammation around the joint or the limb. Differential diagnosis, there are lots of things that can do it, but the fact is that it's usually none of these things. But a stress fracture, especially in an athlete, so if you're looking at a kid who's really active, or Osgood-Schlatter's disease, which we're going to talk about a little bit later, JIA, fibromyalgia, there are some other things that can do it, osteosarcoma or rickets, but these are very uncommon compared to benign limb pain. Almost a guarantee, I can almost promise you that you're going to get a limping toddler on your exam. I don't think I've ever known anybody who took this exam who wasn't faced with a limping toddler. So the most common diagnosis is transient synovitis, which is a viral illness. It actually follows the viral illness. The thought is that the virus provokes the production of an antibody that then reacts with the normal antigens on the synovium. So what you end up having is this basically an autoimmune reaction, inflammation within the joint, and the kid presents with hip pain. The differential diagnosis should include occult fractures and infections. If you're going to do imaging, if it's of the hip, the ultrasound is the best. If it's in the leg, X-ray is the best. But usually with the transient synovitis, it's in the hip. You may or may not even need an X-ray. The gold standard, of course, if you're considering septic arthritis or a bacterial infection within the hip, is to aspirate the hip. But there are a couple of things that can help you. So lack of weight-bearing fever and elevated CRP or ESR, those are both acute phase reactants, or an elevated white blood cell count. Those are all things that will help you decide if this, in fact, is an infected joint with a bacterial infection. All right, radial head subluxation. Very common injury, usually 1 to 4 years of age. Girls, for some reason, are at higher risk than boys. And although every one of us and probably most kids these days experience this activity, it's a setup. The most common story, actually, is that somebody was holding the toddler's hand and the toddler went to stumble or fall, and the natural reaction of the adult is to jerk the arm up, right, to keep them from falling. And that's what leads to the subluxation. So it's a sudden traction on an extended pronated arm, and the annular ligament is moved away from the radial head and becomes trapped in the joint. You get the typical history usually, and the child comes in with the arm held close to the body with the elbow flexed and the forearm pronated, and they have a hard time supinating. It's usually non-tender, not painful. There's no external evidence of any trauma. You can make the diagnosis with your history and your exam. An X-ray is probably not going to help you much unless the history causes you to be worried about a fracture. This is a very accurate way to reduce the nursemaid's elbow. The only inaccuracy in the drawing, some of you might observe, is that avatar looks a lot older than the kid who's typically at risk. After reduction, typically the child will use the arm immediately. No further treatments necessary. A lot of education about what causes this. Refer if there are several attempts at reduction that fail or the child refuses to use the arm after the reduction. Clavicular fracture, also very common, almost always the result of a fall, usually falling on the shoulder, sometimes a result of a blunt trauma, like a bat injury or something like that, and then rarely the result of a difficult vaginal delivery, but it does happen. Often pain at the fracture site. If there's a deformity, you may see some skin tenting. It's where the skin actually pops up over the fracture. You can make the diagnosis usually by history and physical, but a plain film helps as well. Fracture is usually apparent. And almost all cases, there's no surgery indicated. If there's significant displacement of the fracture, you may consider a surgical intervention, but even then, not necessarily. So some sort of non-invasive measures to help promote healing, some gentle shoulder exercises, and they all do fine. Congenital torticollis, child presents with a rotated neck. Usually between the ages of 2 and 4 weeks is when they present, and often there's been a breech presentation. So this is a representation of what it looks like. And nobody's sure of the etiology, but the proposed mechanisms involve malposition of the baby's head in utero. There's some evidence that there may be some injury to the sternocleidomastoid muscle, that this could impede some growth of the muscle and result in a contracture that then has the child presenting the way they do. You may notice some facial asymmetry. There may be some restriction of the patient's ability on the range of motion. The head may be tilted to the affected side, as you saw in the picture. You may actually be able to palpate sort of a mass in the muscle. But the diagnosis is usually clinical. You generally don't need any sort of other diagnostic modalities. You might do a cervical spine film to exclude underlying congenital abnormality or a subluxation at C1, C2. And the treatment is again, pretty benign. You can get a physical therapist involved. There are some stretching exercises. Rarely do you need to entertain any other possibilities such as surgery. So take a careful look at that picture. And think about the diagnosis. So what diagnosis is demonstrated in this X-ray? Is it spondylolisthesis? Is it B, leg calf Percy's disease? Is it C, skiffy or slipped capital femoral epiphysis? Is it D, developmental dysplasia of the hip? Or is it E, Osgood-Schlatters disease? So I'll give you another look at it. Okay, and take a crack at it. Grab your button box and make a choice. Okay, right. This is indeed leg calf Percy's disease, which is idiopathic necrosis, osteonecrosis of the femoral head. It'd be nice if people didn't name diseases after themselves, wouldn't it? We could just call it idiopathic osteonecrosis of the femoral head. Then you'd know what it was. Usually around the age 4 to 8 years, usually unilateral, much more common in males. They present with limping for 3 to 6 weeks. Activity tends to worsen the limp. The symptoms are worse toward the end of the day. And they may complain of some aching in the groin or the thigh. Diagnosis is made through the X-ray you saw. It's an AP frog leg. Can help if their legs are frog. That one wasn't. You see increased density of the femoral head. In the early stages, it might be normal. So you might, if you're entertaining this diagnosis, you might need a repeat film or an MRI. But there it is. You can see that sort of moth-eaten appearance of the femoral head. Treatment is bracing and bed rest, sometimes protracted traction, long periods of time of traction. The goal is to revascularize the femoral head. Sometimes you need surgery to remove the necrotic bone and replace it with so that it can be replaced with viable bone. And if it's not too severe, you might be able to get away with observation. Okay, we're going to make a transition to a different age group. So here's a question for you. In examining the left hip of a 3-day-old male in the nursery just prior to discharge, you don't think you're able to dislocate the hip, but you do feel a significant click when you abduct the hip. The right hip exam and the remainder of the exam, including the neurologic exam, are all normal. Family history is negative for hip dysplasia. Prenatal and delivery histories are unremarkable. The presentation was not breech. The baby's doing well and is ready for discharge. Which of the following is the best choice for the management of this finding? A, double diapering for 1 month, then re-examining. B, MRI of the hip prior to discharge. C, plain x-rays of the hip prior to discharge. D, ultrasound of the hip prior to discharge. Or E, no imaging studies or treatments now, re-examine in 2 weeks. Which of those is the best approach to this patient? Okay, so you guys have read the guidelines. That's good. Ultrasound's not a bad choice, but actually follow-up exam with a click in 2 weeks is the recommendation. Developmental dysplasia of the hip is reasonably significant. And as you guys who examine these hips in the nursery know, there's a variety of spectrums of findings. The problem is that the disease affects the proximal femur and acetabulum. And the real problem is that the acetabulum does not have contact with the femoral head. So early diagnosis and treatment is important. In fact, there are some that believe that the large amount of adult osteoarthritis that exists may be partially the result of undiagnosed hip dysplasia in newborns. So it's this disruption of the contact between the acetabulum and the femoral head, and without that contact, then neither develops normally. So early development of the hip is critical to make sure that this system develops the way it's supposed to. So the object is to bring the femoral head in contact with the acetabulum. The screening maneuvers that you know about are the Barlow, which is the sign of exit, where when you flex the femur and adduct it with posterior directed pressure, you're able to actually dislocate the hip. And the Ortolani, which is an abduction and flexing of the femur, you feel a clunk as the femoral head is reduced and slides back into the right place adjacent to the acetabulum. So you're supposed to screen in the newborn nursery and then with every well visit until age 1. Clicks are generally benign. They're palpable. They tend to be higher frequency noises or feelings as you're stretching or snapping the joint capsule. And those usually actually resolve within 2 weeks. So the AAP recommendations now are to screen all newborns with Ortolani or Barlow. If it's negative, look at the risk factors. If it's positive, refer to an orthopedist without imaging. If it's equivocal, which many of them are, then repeat the exam in 2 weeks. And if it's positive, refer to orthopedics. If it's equivocal, then think about doing an ultrasound. If it's negative at 2 weeks, you can, again, consider the risk factors. And the biggest risk factors are the breech presentation, which was mentioned in the history. But others are being female, 4 to 8 times more common, having a family history, especially if your mother had it and you're a girl, that leads to concern. The breech presentation I talked about, multiple gestation, first pregnancy, high birth weight, oligohydramnios, and any other associated musculoskeletal disorder. But I put at the bottom just to remind you that only 25% of affected babies have any risk factor other than being a female. So although these risk factors are important to know and pay attention to, 75% of the babies aren't going to have any of them. And imaging, ultrasound of the joint space is best for less than 6 months, but after 6 months and certainly by 8 months, those spaces have ossified and it's better to get a plain x-ray. One of the other things the literature has shown is that ultrasound is very reader dependent, and so there's a lot of variability in the readings that you're going to get from your radiologist on the ultrasounds, less so on the plain x-rays. Complications, premature degenerative joint disease, which I mentioned. You can get the osteonecrosis of the femoral head and deformity or hip instability. And the goals of treatment, like I mentioned, is to bring that femoral head in contact with the acetabulum so that normal development can occur. And this is what's called the Pavlik harness. And you can see what that's doing is flexing at the hip and knee and pushing the femoral head into the acetabulum, so there's continuous pressure and contact there. Okay, guys, we're in the home stretch here, and we're going to talk about your favorite topic, which is development. And I'm not going to torture you with this, but what I am going to do is sort of give you a framework through which you can think about how you want to organize this information, and you can consider the ways in which you want to start to actually memorize this. And again, if you can put it in a framework in your head and sort of pick the major milestones for each of the groups and in each of the age groups, I think you'll have a much easier time with it. And one of the better ways to do it is do a whole bunch of practice questions. So once you feel like you're starting to get the gist of it, then do a bunch of practice questions. If you do this, these questions are mostly gimmies. Okay, but it does take the investment of the time and energy to memorize all this stuff. So what I've done for you in the rest of the slides in the presentation is I've broken it down into these age groups, which is pretty typical for the board questions. So 3 months, 6 months, 12 months, and so on. And then I broke it down by task. So you can see the tasks by age over here: gross motor skills, fine motor skills, cognitive skills, language skills, social skills. So we'll go through a few slides, but I'm not going to kill you with all the slides because it's just memorization. And so pick out a few. So by age, by task, and think about how you're going to approach the question. One of the questions that came up in the break, which I think was a good one, is, are you thinking about sort of the upper end of abilities? Are you thinking about the lower end abilities? Are you thinking about the middle? The typical questions that I've seen have said, predict the age. So if the question asks you to predict the age of the child, you're sort of thinking about the average child. So typically they'll give you a couple tasks that the child can do and a couple tasks the child can't do, and you have to come to a decision about where you think the middle age is. And I think that's the best approach. So think about motor skills in a 3-month-old. You want to think about the fact that they can lift their head up when they're held, that they can grasp a rattle in the fine motor. So pick 1 or 2 things in each of these areas and just memorize it. And again, try to paint a picture of the kid in your head and think about a patient of yours maybe, or think about your neighbor or your niece or nephew, or create a picture of the child so that you can remember. That's, the studies with memory, they actually have shown now that the best way to remember something is to create a really absurd example or a really absurd thought. It's like if you want to remember where you leave your keys or something like that, if you create some absurd story about why you left your keys there in your mind, then you're more likely to remember it. So by creating pictures in your mind, you'll have a much easier time remembering these things. So cognitive skills responds to the shaking of a rattle or bell. Language skills, cooing, responsive smiling. So the second one here at 3 months, responsive smiling is sort of classic. Being able to react to a peekaboo game. At 6 months now, the baby's able to hold the head steady when sitting in a sitting position. They can reach for an object as opposed to just hold it when it's given to them. They can physically shake a rattle. Open their mouth for a spoon when it's presented to them. 6-month-old will be babbling, will know familiar faces. And then 12-month-old, I always think of the 12-month-old, the ones that I think about are being able to drink from a cup, being able to feed themselves finger food. They develop the pincer grasp. I think about their ability to pull to a stand and cruise. I always associate that with 12 months. Being able to grab and pick up objects such as little toys. The cognitive skills, they can respond to their environment more now. Object permanence, you remember what that is? If a child has object permanence and you show them an object and then you put it behind your back, the child will look for it. A child who doesn't have object permanence, if that object is not in their sight, that object doesn't exist. So you show them an apple and then you put it behind their back, and to them the apple's gone. It doesn't exist anymore. So that's a child that lacks object permanence. But by 12 months, they have object permanence. So if you take something like that and you hide it, they'll actually look for it. Language skills, they're saying their first words at 12 months. They're able to raise their arms to be picked up and follow very simple commands. Sort of 18 months now, we're going from 12 to 18 months, a big jump. They can stack 2 blocks. They can walk without help. At this point, they're walking on their own. Cognitive skills, they're able to laugh responsively to a silly action. They can follow a 1-step command. In language, they'll have some simple words like hi and bye and please. They're able to bring a toy when asked to. They're able to play by themselves and have an interactive play by themselves. By 24 months now, drinking from a straw, feeding themselves with a spoon. Again, pick a handful of these that are familiar to you or that you want to use as sort of comparable milestones to one another, and maybe even make a chart for yourself so you can track how they go across. This is another big one they often pick is able to point to or recognize body parts at 24 months. Language and social skills, now we're using 2 to 3 word sentences, so we're able to put words together to make a sentence. 36 months, 3 years, And again, you get the drill now. You pick a few of these with each one, and you'll get to a point, hopefully, where you can name the age of that child. And again, that's the goal. Okay, so I'm flipping forward here to a couple questions that are going to round out the session. So this child can sit well without support. The child can pull to a stand and cruise. She can feed herself finger food, point to objects of interest, and raise her arms to be picked up. She knows when you hide her favorite toy under a blanket to look for it. She does not follow one-step commands, nor does she ask for things by pointing. How old is this child? Grab your button box. So I think that's a good choice. You're picking sort of the middle of the group for those abilities. You're really probably looking at a 12-month-old. Right, this child can feed himself with a spoon, build a tower of 3 blocks, walk up steps with help. He has a vocabulary of over 200 words and combines 2 to 3 words in his speech. He laughs at simple humor and can point to basic body parts when asked. He does not use or know his first and last name, nor can he identify colors. How old is this child? Right. So I as well picked 24 months, so I think that's the closest to the right answer. So I appreciate your attention and best of luck on the exam. Thank you.